Our next speaker, you may have heard that Saskatchewan's made a real effort to bring down surgical wait times. So we have Mark Wyatt, the Executive Director of the Saskatchewan Surgical Initiative. He's going to tell us how this was done.
Good morning, and thank you for the opportunity to tell our story about the Saskatchewan Surgical Initiative. I'm going to take a moment just to explain what the initiative is about and then talk about a few of the areas that highlight specifically the themes that we're talking about at the conference around efficiency, sustainability, and also patient-centered care. So it seems a little bit outdated to be talking about wait time and surgical wait time reduction. That was so 2004, 2005, but it is still very relevant in Saskatchewan. I think it is still relevant probably in many jurisdictions. Some of the polling that we saw a little bit earlier talks about access still being one of the major areas of concern. When our new government came into Saskatchewan, they conducted a patient-first review, which was a little bit different than a lot of the healthcare reviews that we've done across Canada in the past. Rather than talking to all the usual suspects, they made an extra effort to talk to patients. And what they came across was not surprising, that the perception, and in Saskatchewan I think the reality as well, was that access to surgery, access to diagnostic imaging were the top of mind issues. Of course, the one thing that came out of that was a lot of the issues that also are addressed in the polling, so thank you for covering that in your presentation, Mr. Wright, around the issues around coordination of care, communication, and the care experience that patients perceive that they experience when they're going through the system. So as we looked at how we were going to address that top of mind issue, we called it the lead out strategy following the patient first review. It was about how do we do this in a different way than we've done wait time reduction in the past that will bring a short-term breakthrough approach to wait time reduction, but also look at how we make the system sustainable for the future, that we not just bring down that wait time backlog, but change the system to avoid future backlogs from developing, and at the same time to be true to what we heard through the patient first review. Part of that was to take an approach that not just focused on wait times. While wait times are clearly the issue that has captured, and access is the issue that's captured most of the public discussion, we brought a real emphasis around safety, quality, patient experience, and efficiency. Our motto with the Surgical Initiative became sooner, safer, smarter, and the unspoken fourth S was sustainability. We looked at the NHS and the work that had been done there, where they've committed to a national 18-week wait time maximum for surgery. And we looked at that approach both in the simplicity of communication to the public, the simplicity of managing that and getting rid of all of the different benchmarks that we'd began to develop during the 2000s for individual procedures, and basically came along with a commitment that all patients should have the opportunity, the option of receiving their care within 3 months from the time that it's booked with their surgeon. The other thing that became critically important is, and I think the lesson has been learned, that certainly Saskatchewan right now, for the past few years, has been experiencing a strong economic times. Potash is good, uranium's been good, oil has been, for the most part, good. When you look at what happened to the NHS after they got their wait times down to that 18-week standard, the European economy has obviously changed, and so they're now dealing with how can we actually maintain that without either backing away from that commitment or continuing to eat the rest of the system's lunch, whether it's education, social services, or even within healthcare, to what extent hospitals are eating the lunch of mental health, primary care, some of the other issues we're talking about. So the initiative, it's on a 4-year time frame prompted by the patient first review. We were experiencing some progress, but at the rate we were going, we figured it would take us about 30 years to get to wait times that most people would consider acceptable, modeled after the NHS, and a recognition that simply adding more wasn't going to work. The approach we've taken is probably Well, one way of describing it is a combination of brawn and brains. Given a 4-year time frame, there was no way that we were going to be able to get from the extensive wait list that we had down to a 3-month maximum in a 4-year period. So we absolutely needed to add some additional capacity, bring up our volumes in order to bring down that backlog, and then in the future manage the recurring demand. One of the ways that we did that, Jeffrey Simpson talked about it earlier, was the introduction of privately delivered contracted day surgery facilities through a publicly funded contracts with our regional health authorities. I won't speak to it in great detail, but other than to say it's been a really important part of being able to introduce capacity into the system where we needed to increase both our day surgery and our inpatient surgeries by moving some of those short knee arthroscopies, cataracts, dental procedures out of hospitals and into a clinic, community clinic setting where they can be done safely. We've opened up a lot of our capacity in our publicly funded hospitals and been able to quickly mobilize more capacity both for inpatient and day surgery. The fact that it was done at a lower cost than what it would cost our public hospitals to deliver that service. Initially, the cost difference wasn't that significant. As we've become, I guess, introduced a more competitive process, we have seen some pretty significant reductions, and we would see this as part of our ongoing efficiency that we've built into this initiative. The other issue, though, that we encountered is just lowering the waterline and just doing more surgery. Yeah, it's helped us to a great extent, but the problem was we have a huge distribution issue. I'm not sure to what extent it exists elsewhere, but what we found is when we looked at our long waiting patients, those over 12 months, those over 18 months, half of them were on the wait lists of 10 surgeons in our province. 25% of our long waiters were on the wait list of one surgeon, an ear, nose, throat surgeon, lots of small procedures. But in terms of volume, this was huge. So we had to find a way of dealing with that distribution issue. One way is just to allocate more OR time to the guy with all the long waiting patients, and we actually did some of that. But what you soon find is there's a feast or famine impact where those who have those long waiting patients, they can't do any more than they're already doing, and the incentive you're creating, frankly, is to tell the rest of the world the more you do, the more OR time you're going to make, and sending the wrong message. So here, I just want to talk about a few of the strategies we've used that I think incorporate that whole idea of patient involvement and patient choice in their care. We're pooling referrals. I'm going to come back to that in a moment. One of the things we did with some of those surgeons that had huge long lists was talk to them and get agreement that we would contact or they would contact patients and offer them the choice to move to either a new surgeon, a surgeon with a shorter list. And again, it was always the patient's option. We didn't tell anyone they had to move, but to at least pursue that. What's more important to you as a patient, to wait for another year to see this particular surgeon or potentially have an option for care in a much shorter time frame? Our rural service patterns, we have a lot of patients who are bypassing their hospital in Prince Albert, in Swift Current, in Yorkton, and Moose Jaw, and going into Regina and Saskatoon. So part of what we're trying to do, again, in terms of managing distribution, is to look at how we get some of those procedures that can be safely done in a smaller regional hospital. Clinical pathways, one of the other presenters will speak at greater length, but we are definitely using clinical pathways as a way of trying to both streamline the process for patients, but also look at where can this, do many of these procedures need to be done through surgery? Do they require a visit to a surgeon, or by using either advanced practice therapists, nurses, can we begin to triage some of those patients who are clearly not surgical candidates? Our neurosurgeons, for example, said that for every 100 patients they see, maybe 10 to 20% are actually surgical candidates. So why can't we take that other 80% and have them visited by a different care provider first? Just looking at patients, pooled referrals as that one option. We now have 15 specialty groups in the province who are pooling referrals. A lot of what we heard is patients won't go for this, and it's true, a lot don't. We continue to offer them the option of either being referred directly to a specialist of their choice or moving, if that's their preference, to get access sooner. And what we're finding is that I'll use our Regina Obstetrics Gynecology group, for elective gynecology, 46% of patients are taking up the pooled option. For high-risk obstetrics, on the other hand, 23%. So it depends a lot on the procedure. We just introduced this a few months ago with our general surgeons in Prince Albert. 80% of patients who were having endoscopy procedures, it didn't really matter who was going to do it for them. Access was more important. For surgery, 60% chose the pooled option. This graph just shows you the impact it had in a 4-month period with our Regina OB/GYN group. We reduced the longest waiting patient by over half, and the mean, the longest went from 165 to 74 days wait to see an OB/GYN. The mean wait went from 40 to 24. I know I've just about run out of time, or I already have run out of time. I'm just going to talk briefly about lean. You may have heard that Saskatchewan is going lean big time. We've dabbled in it. Now, as our Deputy Minister, sorry, I was going to say John Wright because I see John Wright. Our current Deputy Minister, Dan Florazone, would say we're putting lean on steroids. I think we're putting on human growth hormone and a lot of other things that cyclists have probably never heard of. And I would say lean sounds like it's all about savings and it's all about efficiency, and we're absolutely expecting lean to deliver savings and efficiency within the surgical area. We've got 40 intense rapid improvement workshops coming, 1-week-long workshops coming up in the coming year, just on the surgical service line alone. The one thing I would say through my own experience, I'm going through the certification, as many people are in the province, is I think it will deliver the dark green dollars in savings. It will bend the cost curve. Frankly, our early experiences, we're finding some of that. Where I think it really delivers big time is on patient experience, patient coordination, and that first exercise that you go through of value stream mapping the service. More than anything, it shows you all of the problems that we have with the coordination, the communication with patients. And I think lean, while it sounds like something that, it sounds like, well, it comes from the Toyota production system. It really is going to deliver, I think, as big a bang for patients as it is for efficiency. Appropriateness is another area. I'm over my time, so I'm not going to spend long, but just to talk about that issue of unexplained variation and high rates, high and potentially low rates of surgical rates that we're beginning to look at, and as we look down the road to how do we sustain this, getting inside that black box of clinical decision making is one of the key areas as we see it. Quickly, just to close, this shows you over 2004 to 2012, and you can see that slow trajectory that we were on for most of the 2000s. With April 2010, we've reduced the number of patients waiting over 18 months by 92%, the number waiting over a year by 82%, the number waiting over 6 months by 60%, and over 3 months by 49%. We're fairly confident we're going to hit our goal of 3-month surgery by April 2014 in Saskatoon and most of the regions. Regina is, I guess, experiencing some difficulty. We'll probably need another year there. For us, victory looks like not just providing better access, but better safety, better quality, and frankly, taking surgery off the agenda in Saskatchewan so that we can focus on primary care, mental health, and other things that will have truly a bigger impact on health. So thank you.